I think we can start now. Good evening, everyone. Welcome to the webinar on compartment pressure syndrome. My name is Harish Litta. I'm from Rehab Care, an Australian-based company working alongside health professionals. I'm pleased to welcome Dr. Corey Cunningham, who will be sharing his valuable knowledge and experience on this subject. I know Dr. Corey Cunningham don't need a lot of introduction, but he's a sports and exercise medicine physician based in Sydney. Please feel free to ask questions using a chat thing on your screen on the down below. You can do this anytime during the webinar, and Corey will be answering these questions for you. You can contact us at any time if you have any questions. Without taking too much of your time, I'll hand over to Corey. Thank you, and once again, welcome. Over to you, Corey.
Great, Harish, thanks very much. I'm just going to share my screen and get our talk ready to roll. Hopefully that's visible to everyone. I will monitor the chat function down the bottom as we go along. Aim of this evening was asked to chat about compartment pressure testing, basically to describe this device that I've been using for a couple of years, which makes the whole pressure testing really practical and really easy, whether it's any muscle compartment around the body. And but in order to get to that stage, we want to have an understanding of compartment syndrome when you should do the testing. So those of us doctors who worked in hospitals or worked in sport, unfortunately do deal with fractures and trauma along the way. And the very serious compartment syndrome is obviously the acute compartment syndromes associated with a fracture or a crush injury in a worksite or motor vehicle accidents, or as we're all taught, caution about a plaster that's too tight and an underlying fracture that swells. What we deal with in practice is often the ongoing pain associated with exercise or exertional type pain. And there's a number of causes for that, obviously, which we want to investigate, part of which involves the compartment pressure testing. Remember that compartments exist in the upper limb and lower limb. By far the most common we see is lower limb stuff, but certainly BMX and dirt bike riders and workers get flexor compartment forearm pain. And the beauty of testing with a simple device, I guess, is that you can put a needle into any of these compartments and understand the pressures. When we think of exertional lower limb or calf pain, chronic exertional compartment syndrome is a fairly common cause. Others that we consider probably rarer but still to be concerned about is popliteal artery entrapment. And from a clinician point of view, it can be difficult to distinguish between the two, but we should always be thinking about them. Obviously, runners and athletes with exertional pain can get stress fractures. So it's really important as clinicians to be aware of the typical history associated with stress fracture, which is often increasing pain, difficulty weight bearing, and night pain or prolonged pain after exercise. Periostitis or medial tibial syndrome is very common and often a function of biomechanics, of footwear, of training loads, and that obviously causes that long-term medial tibial pain, which is present at rest and with exercise and flares up, often warms up and then aches afterwards. And those who treat it know that it's often associated with a lot of tenderness along the medial border of the tibia. Key thing to remember is that someone with exertional leg pain can have multiple pathologies, and you can have mixed compartment syndrome and popliteal artery entrapment. You can have chronic periostitis and develop a compartment syndrome. And hence in our diagnostic kind of workup, we're trying to assess that to target our treatments. Also remember that pain can be referred from the back. Most clinicians are very good at thinking through that and trying to assess the back or the pelvis as a source of referral pain down into the leg. When we think of a compartment, it's maybe pretty obvious, but think of it as not just the muscle, which is getting swollen and engorged, but also the surrounding fascia. And oftentimes we see compartment syndrome in older, not so much in adolescents, but obviously 20s, when the compartment, the fascia thickens up and it becomes much less elastic or compliant, and that's thought to be a contributing factor. And the thing that generates the pain is not just the muscle swelling, but its effect on compression of the neurovascular bundle. And that gives rise to the typical referral patterns we see down into the leg. Typically, if we're talking about calf, because it's the most common that we'll see, then we think of the anterior compartment in here where tibialis anterior runs through, the lateral compartment and its fascia here, deep posterior, predominantly tib post, but also FHL, and then the gastrocsoleus superficial compartment. This picture is included because it's pretty useful to think that a good spot to get all those compartments is about 10 centimetres below the tibial tubercle. You've just got to pick a spot where you want to put a pressure gauge in to measure those pressures, which we'll talk about shortly. Classic things to consider when we're talking the chronic exertional compartment syndrome is the history. Defence is probably the group. Defence and soccer are probably the two groups that I do the most testing on, as would many of my colleagues. It's often related to footwear and ground interface, to sudden increases in loads, lack of recovery time, and often younger people who are developing strength and muscle bulk, all of which contributes to the onset of the symptoms. Typically, the pain's pretty insidious. It's not like one game you develop symptoms and you didn't have it the previous. Typically, it's gradually getting worse. It's described as a crescendo pain, as in it increases the more activity you do and the more you keep running. It's often described as crampy or aching and sometimes sharp. It refers into classical distribution, so that's often related to the nerve that runs through that compartment. The anterior compartment, if that's solely isolated, will tend to radiate down to the dorsum of the foot, whereas the deep posterior aspect especially runs down into the plantar aspect of the foot. So asking about referral patterns, it's asking about paresthesia, as well as pain. Do they feel numbness? And very classically, a soccer player feels numbness over the top of the foot, and sometimes they attribute it to their laces or their boots, but often it's coming from higher up in the entrapment of the superficial peroneal nerve. And then another key point to ask is, how quickly does the pain settle down or disappear? Often with the vascular causes, it settles very quickly. With the compartment syndrome causes, it will settle over minutes, but it can sometimes take hours. Typically on soccer or netball, they can get away with a short rest at half time or even in between bursts of running, which allow it to settle enough to get through a game, but typically they struggle towards the second half. It's relevant to know, have they had a lot of treatment? Have they had assessment of biomechanics? Has anything been done to release tight muscle groups? Have they graded their training? Are they taking supplements, which can lead to some fluid retention? There's a lot of factors to consider, not just a muscle swelling within its compartment. So typically, examination is very normal. There's no tenderness, there's not much to see. They have perfectly normal pulses. Sometimes you see a fellow like this who've just got tight or tense muscle groups, and they're obviously working on building those muscles. In any lower limb examination, we're looking at lower limb alignment and biomechanics for other causes and correctable causes. And we should be checking for pulses, and if it's practical, you do it pre and post exercise. But that's obviously looking for a vascular cause rather than a pure compartment syndrome. The other one to consider is popliteal artery entrapment. The popliteal artery runs down dead center down the middle of the calf. It runs between the two heads of gastrocs, and then ideally it runs over the top of popliteus and tucks down under soleus. Now, popliteal artery entrapment implies that that blood vessel with exercise, usually compression by the gastroc muscles, gets obstructed, reducing blood flow, creating ischemia and then pain. By far the most common is a functional cause, but we always, which is typically induced by overactive medial gastroc head. But we always want to look for or consider the anatomical causes, because they're the ones that are reversible. They're the ones who might be able to change and take pressure off the artery. Oh, Harish, I just realised, sorry, I wasn't watching for chat questions, but I'll have to keep an eye on that. Sorry, guys, if I've missed you. And then, so the next thing to talk about is the anatomical variance. Now, this is a bit of an academic thing, but what you look for is, does the popliteal artery run down the middle of the popliteal fossa or not? It can run to the medial side of the gastroc, like in a type 1, type 4-5, there's a little slip of extra tissue which compresses the artery because it becomes a tight band. Sometimes there's a slip or a band of medial gastroc which runs between popliteal artery and vein and can compress one or the other. There's lots of variants. It's generally considered there's 6, or number 6 just means and all others. And we kind of investigate for this often in someone with ongoing symptoms, and certainly in terms of pre-op planning. And so, sorry. My other thing I want to point out is that if you've got time or you make effort, you can listen for a popliteal bruit post-exercise, which is just a measure of turbulence and increased blood flow. The differences in history taking, there's obviously mixed and overlapping symptoms, but often with popliteal artery entrapment, the pain comes on pretty quickly, and it's a bit more global, like you don't get an isolated anterior or lateral compartment. It can obviously compress an artery, a branch of the artery which supplies the anterior compartment, but it's global. It often causes achy pain and it extends down under the foot. Something I've noticed is that the pain will settle quickly as they cease exercise. Blood vessels open up really quickly. And so when we start to investigate, we are thinking, what are the different causes that we can identify and treat, basically. And clinician will do that on the basis of the patient presenting to them and how long they've had it. But some of the things to consider, and just to talk through the practicality, or the way I consider it at least, is that we might be doing X-ray, MR, arterial Doppler ultrasound. It may or may not go into CT or MR angiogram. MR angiogram is a good test, but it's a really difficult test to do, basically to identify popliteal artery entrapment on the MR. You've got to try to hold a calf contraction for 3 to 5 minutes so they can run the sequences. So that's not always so practical. And then, of course, if we're worried about the pressure increase, we can measure it. And where that's leading to is potential surgical options. X-rays are really cool and often forgotten. As we know, anterior cortex tibial stress fracture can oftentimes delay presentation. Is 6 or 9 months. It can cause exercise-related pain. You can pick up aneurysm of bone cysts or benign bone tumours, particularly in an adolescent or a growing athlete who shouldn't really, unless they have an anatomical variant, shouldn't really develop a compartment syndrome or have a popliteal artery entrapment. So always consider that if not responding to treatment, imaging is important, and X-ray is a good place to start. MRIs are really good, and obviously it's now available. There's no radiation. It can help provide information about a lot of those variants. And in this setting, I'll always ask for an MRI of the calf, including views of the popliteal fossa, because clearly it's better to do all the scans while they're there at the time. And most radiology practices you work with will be very happy to accommodate some views up around the popliteal fossa. Stress fractures are highlighted very well. You can see the cortical crack as well as the periosteal edema. Sometimes, unfortunately, we pick up soft tissue tumours in the muscle, which can masquerade as muscle swelling, and you might just see a sarcoma one day, particularly in the patients who are just not responding to treatment or not getting better. Doppler ultrasound is probably, if there's any vascular element, would be my initial go-to test. Obviously the benefits are that it's non-invasive, there's no radiation. You can assess bilateral pathology really easily. And you can do dynamic studies, which is clearly what happens to compress the popliteal artery. So what they look for is not just blood flow through the artery, but turbulence as the blood goes through a kinked or narrowed compartment. And in doing that, you've got to get someone to contract their gastroc. It's not quite as simple as just plantar flexing at the ankle, but often it's done with people standing up. So they go up onto their toes and hold a position for 20 seconds or so, if they can, to see if the gastroc contraction compresses the artery. Everybody has different flow rates, so we tend not to look for a certain number of flow, but the radiologists tell me they start to report positive findings when flow rates increase by about double from what their baseline is. So that can be a very helpful test. There's no doubt that we'll often do that and think this is classic and their symptoms are quite disabling and a vascular surgeon might be involved, but they'll want angiogram to define it a fair bit better. Again, it's good in the presence of bilateral symptoms because you can do both sides. This picture in the middle is a CT angiogram. And if we're looking from behind the patient, this is their left leg and this is their right, you can see clear obstruction of the flow at the level of the popliteal artery or the popliteal crease, consistent with obstruction in this position of ankle plantar flexion. So what happens here is, this is a good one because you can just put a cannula in at the elbow and insert some dye, and then about 30 seconds later they can take a whole series of images on CT scan and watch the blood flow down into the leg. That's usually quite a practical test that patients tolerate quite well. The other one, digital subtraction angiography down the bottom, is more difficult. It's an angiogram, so the dye goes straight into the femoral artery and you can watch. And this is a good example down the bottom just because it shows what happens if you have chronic obstruction in the middle, assuming that's about where the popliteal artery is. Then you can get this massive collateral compared to the other side, or medial geniculate, or one of the arteries in and around the knee, which help to provide blood flow distal to that stenosis or that lesion. So perhaps that one's been there for a prolonged period of time, and as we know, arteries especially and compartments adapt quite well, and the body will create new flow around the level of the obstruction. You might also consider angiogram. If someone has a normal MRI scan, you've probably done compartment testing and it just doesn't make sense. They could have vascular malformations or atherosclerotic disease, particularly in the older patient. However, if they have crescendo pain, which is affecting running, affecting soccer, affecting netball, affecting their career in defence, then we want to investigate oftentimes and know what those pressures are. When we're measuring the compartments, clinicians will make decisions. Do we measure all compartments or only the symptomatic ones? Do we do a pre-exercise baseline, or do we only measure it post-exercise when they've got symptoms? Clearly, the post-exercise group time is the most important, because that's when they've got symptoms, and that's what we want to know. Some of the older devices, you used to put a catheter or a cannula into the leg to get a pressure, then have to exercise and then re-measure the pressure. With this Compass device, one of the beauties is that it's a single unit, and effectively it's just on the tip of a needle. So you can put it in a compartment, measure the pressure, take it out, then go exercise and measure it again. So in that setting, I tend to do pre and post exercise pressures. But if all their symptoms are deep posterior and plantar aspect of the foot, then I'll just do the posterior compartments. Or if it's all just anterior compartment, anterolateral, and onto the dorsum of the foot, I'll probably just do the anterior and lateral compartments. But that's a decision made depending on your exact patient and their tolerance. So if we want to do it, it should be pretty easy. And I'll encourage people that anyone who's comfortable doing injections, if you actually have the pressure device that you can attach to your needle and syringe, then it's just like doing an injection or putting a needle into any of the compartments. The skills are obviously to understand the anatomy of the compartment, and ultrasound guidance can certainly help, especially when you're talking about the deep posterior compartment. But often in the patients, as you know, that we're dealing with, they're tight and they're tense. And for example, in this picture, you could easily feel the anterior compartment. From a practical point of view, I put a mark about 10 centimetres below the tibial tubercle. So I'm in the same compartment, about the same level on both sides if I'm doing both sides. And also once I've come back from exercise and they're sweaty, you know about where you put the local anaesthetic, so it's much more comfortable for the patient. I do local anaesthetic bleb under the skin, and then let that work. And what you need basically is a device. This one's called a Compass pressure monitor, some saline, 5mm syringe, and an 18 gauge needle. And I've been using a standard needle. I know that there's specific needles that people used to use for other pressure systems with a side port, but I've just been using a standard 18 gauge needle. And that device is obviously for single use for this testing, as in you can use it for all the compartments. And indeed, we're talking about muscles and sports medicine here, but it's often used to measure pressures in veins, to measure pressures in arteries, to do acute pressure in emergency. You've just got to know what the pressure is in that leg that's been crushed. Do we need to operate straight away or not? So in our sense, I guess we're using it quite a lot across maybe anterior, lateral, deep posterior, superficial, so maybe 8 compartments in the one test. I had a video of me doing it, but it wasn't nearly as good as a simple animation, which just shows how kind of simple it is. I might just play this, Harish and everyone. I trust that it will work because it makes a lot of sense. And so from a practicality point of view, you load up your syringe with the 5 mils, put the needle on and flush it through. And then you've got, that's when you press the
I'm Dr.
button.
Jess Mason, and this is Dr. Waleed Hammoud, and we are going to show you how to check compartment pressures. Does that sound good?
Sounds great.
Let's do this. Why don't you get that all sterile and anesthetized? Now we're going to do this in 3 parts. First, we are going to show you how to set up and calibrate and use the Stryker intracompartmental pressure monitor system. Then we're going to do a little bit of a review of the anatomic compartments and where to insert the needle for each compartment. And finally, we're just going to top it off with a little bit of rainbow sprinkles and do some pathophysiology right there at the end. All right, so there's one thing you need to remember before you start, and that's the number 30.
Holy moly. Sorry. I thought that was at your end, Harish. I couldn't stop it.
That's on me.
Okay. So from a practicality point of view, what I'm saying is that basically load up the syringe, flush through the device, and then press the little button to zero it. And then once you're in, I'll put maybe 0.5 ml to just flush out the tip, because you might pick up tissue on the way through, to flush out the obstruction of the tip. The pressures do tend to go high and then come down and settle. And but I've had consistent measures. I know that I've talked to a number of colleagues who say in using the device, sometimes the pressures are a bit low and, you know, this patient's definitely got symptoms, but their numbers are so low. I maybe had that once or twice. I don't know exactly how or why, but I know that a number of studies have been done calibrating the device, and the pressure error is pretty small. So maybe they're a variant that we don't understand, or maybe it is a device issue, but it's not a regular problem. If you're going to do it, then most of us still talk in terms of measuring pressures according to the original 1990 Pedowitz criteria, which is now obviously 30 years old. And over that time, there's been lots of studies relating to pressures and what's normal and what's abnormal. Indeed, it can be very normal to have pressures of 30 in some people. And I guess from a practical point of view, that's why I will often do pre and post pressures to demonstrate an increase. Basically, what we want to know is, can the patient do exercise to bring on their symptoms? And then if I've got a pressure before and a pressure after, does it significantly increase, basically? In which case, releasing that fascia or surgical intervention may well be beneficial for the patient. So typically quoted is a resting pressure greater than 15, but that would be only if they were very symptomatic. The most practical or relevant measure that we go for is at the 1 minute post-exercise, or off the treadmill, or off the stairs, or basically whatever it took to bring on the pain, to set up, and then you've got to be ready to go so that you can start measuring pressures straight away and record the numbers. Like I say, obviously there is an overlap with normal variations, so you need to interpret it with your patient there. And then just because someone's pressures are high, it helps with a diagnosis. It doesn't mean surgery, and indeed a lot of people don't need surgery, but we've got to talk about options, because obviously what they're doing at the moment isn't controlling their symptoms, and they want to play soccer, for example, or netball or run. Or they can't pass their test in defence, which obviously affects their career. Conservative treatment options, including soft tissue releases and specific massage, and there's massage therapists who are excellent in releasing the fascia, may well be helpful. Obviously, a key is to modify their level of activity, which may or may not be acceptable to that patient. If they have clear symptoms, it's interfering with activity, it's progressively getting worse, they want to go back to sport and activity, then we talk surgical options. And previously, people used to do massive cut up and down the leg. The reason for these photos is the ones I've seen often involve multiple small little punctures to be able to get into the appropriate compartment, and then from underneath the skin, slide up and down to open the fascia. Recurrence rates vary, but maybe from 10% to 40%. And some thought relates to, do you just slice the fascia, or do you do a fasciectomy and take out a wedge of fascia so it's much less likely to scar over or reform? From our point of view, that's a bit of a surgical thing, and surgeons you work with or know will give you their opinions. I'm just saying that, yeah, oftentimes don't be concerned that it's going to be a large cut or laceration all the way down, up and down the leg, but the incisions can be quite small. Clearly, the bigger the incision, the more clear it is that you've cut the fascia, but skilled surgeons are very good at working through these small incisions. As I say, recovery rate is actually pretty good. It's a freeing up operation rather than a reconstruction operation, so people can walk on it pretty quickly. Return to sport time is more in the 4 to 8 week mark, but it's certainly over, say, 1 to 2 months rather than over 3 to 6 months, where it used to be the case. The larger the incision has been associated with infection risk, but I see that as a small risk with the smaller infections. So not everyone needs surgery, definitely, but if we can take a good history, if we can do the appropriate investigations, if we can test it in a way that's a bit reproducible and certainly getting at least a reading from a known compartment, then we can at least present options to patients for their treatment. That was kind of the overview of what I wanted to get through. Does anyone have specific questions I can try and address?
Corey, there's a question in the chat box.
Yeah, from Etienne. Yeah, it's a difficult thing, but part of it is being pre-prepared, having your kit laid out, ready to go. I'm often on a treadmill next door, in a room next door, or in the exercise area. So from a practicality point of view, when they're on the treadmill, I want them to bring on symptoms and try to keep going if they can, because that's what they do on the field and that's what they do in real life. And then we'll get back to the bed. And if I'm really concerned, then I will do the main compartment first. But we've already done it once, so I know exactly where to put the needle in terms of anterior lateral and deep posterior. So I guess I feel that if I haven't done it right on 1 minute, I've done it within 2 minutes, and I can still interpret my results reasonably. Sure, Luke's asked a good question about insertion points, and what I was mentioning was we need a point a certain way down the calf where you're going to hit that compartment. Yeah, the more distal you go, there's less muscle bulk, and the more proximal, not so easy. And so anterior compartment is kind of right in the middle of that compartment. I go in at approximately 90 degrees to the muscle group. And like you say, you've zeroed your device before you put it in, and then you flush, and then you measure the pressures. The only one that's concerning from hitting something, hitting an artery, is the deep posterior. And that's the one I'll often use ultrasound for, to slide down on the very medial border of the tibia, and you've got to try to get deep. I guess that's it's a bit more of a practical demonstration question, Luke, I'm sorry, but middle of the compartment. And question about playing on through. I think that the pain is very self-limiting. I kind of often say the pain will limit you more than your exercise or training will damage the muscle or the compartment. Remember that we're talking about the chronic ones. Here, we're not talking about a fracture or someone stuck in a plaster, where acute compartment syndrome is completely different. That's limb threatening, and that's one that surgeons get up in the middle of the night to deal with. with our ones, yeah, they tend to limit performance and self-regulate, take longer breaks. If they can, if they're in a sport where they can come on and off, they'll do that a little bit more. If it's practical, they'll often get through to the end of the season, and I don't see any medical danger or concern in that. But sometimes by the time they present to us, it's obviously very annoying and it's holding them back and it's affecting performance enough that they just want to deal with it. Keep an eye on the chat because that's one I can have open easily. Oh, sorry.
Down below, Corey, in Q&A, right next to chat. Take your mouse all the way down. Yeah.
I can't sit on that screen, sorry.
Right next to the chat box, there's a Q&A.
Mm-hmm.
All the way down in the middle of the screen.
I'm going to have to exit my screen, hey, and that will help us.
Yeah, try that.
Because I'd rather, this is the best thing to do will be to just answer the questions from what we've done. That's because that's what I do. Okay. Oh, sorry, John Best, missed your question there, mate. Yes, when you're doing arterial Doppler ultrasound, that's not something I'm going to do in the rooms. I'm going to send to radiologists. In the ideal world, you do it post-exercise or bring on the symptoms, but in many cases they don't do that or they're not set up for it. As long as you're getting an adequate calf contraction, you can at least demonstrate that with calf contraction, your vessel gets compressed and the flow rate doubles. And then I guess you surmise what happens during training and running. Cool. And to Varan, I'm sorry, I'm just going to work down a few questions. I tend to do it at that same level because that's where I can access the muscle bulk of the compartment. They may well get the referred pain distal, but remember a compartment's a compartment. So as long as I'm in the muscle bulk of it, I'd be confident I'm getting pressures. Sometimes the pressure is normal, and you know that, I'm sure, Varan, that you think it's positive, it should be, but it's not, in which case I'll try another area of the muscle. But as a routine, I tend to do it about 10, 11 centimetres below. Someone's asking about costs of the device. Harris, you can answer that, but it's in the order of $180 to $200 for that disposable device. So it's clearly a cost to a patient. What's good is that we don't have to, service anything or calibrate anything, and it's a single-use item that is just part of the test cost for that person. Yeah, I think to another person about paramedics, it's ideal if it's practical to have it on site, and cost point of view, then it's the ideal thing. It's about 2 to 3 centimeters cubed. So it's easy to have, easy to use, and very quickly you could connect some saline and get a pressure straight away. And Andrew Potter, a colleague who's dealt with exertional lowering pain for many, many years, it raised a very good question here that is the recurrence rate after surgery, it may well be due to scarring of the fascia, as in reforming over the top. They've obviously, by the time we've got to that stage, they've had a prolonged period of disuse, so it can be muscle pain as well. I guess I'd be most keen to know, is it just pain in that compartment, or has their associated referred symptoms recurred? And that'd help guide some decisions as to whether you want to retest, whether you want an MRI scan, or whether you push on with treatment for a little while. And someone's asked a good question, how often do they coexist? Unknown, but I reckon in the order of 10% of patients with the CECS, you're thinking, oh, there might be vascular obstruction as well. Remember that the compartment syndrome tends not to cause pallor or the classic vascular changes. So if that's happening, I would investigate both. I know that the vascular surgeons who send patients to me for compartment testing are all sending it on the basis that they've seen someone with PAS or probable PAS, and they're saying, I want to exclude an associated compartment syndrome before we proceed to operation. The other thing to point out there is that a compartment release is a fairly simple operation, whereas a vascular problem can be quite a very complex, large incision, sometimes grafting, sometimes bypassing. In the ideal world, you want to find one of those little slips of off the medial gastroc, which compresses the artery that can be divided. But a vascular surgery is often a much bigger intervention, and so we want to make sure that you don't need to just release the other compartments as well. Hopefully I answered a couple of those from a practical point of view. Obviously it depends on patients in front of us, what we see and how we approach it, but you come across nothing fits the textbook, as we know, with this kind of pain. And what I want to point out from a doctor point of view is always be thinking, if it's not getting better, or if you're a therapist, if it's not getting better as you think it should, then let's go looking for possible causes, which may start with X-ray, MR, or lead on to compartment testing. Happy if others have comments as well about their experience or positives and or concerns about using this. I've found it good, but I haven't had years of using other devices to be able to compare it with.
So that's any more questions? I think we can conclude the session. Corey, have you got anything else to add?
No, but always happy to chat to anyone or email discussion with anyone who has questions or concerns or experience from their experiences.
Yeah. Thank you, Corey, for sharing your knowledge on the subject today. Sure. I hope all find this session valuable. If you have any questions, please don't hesitate to contact us. We have recorded the session and happy to share the link on request. Thanks again for your time. Stay safe and good night.
Thanks, Mark.
Can you close the session, Corey? I think you've got the controls.